All right, are you guys all able to hear me?
Yes.
Yep. Yep.
So tonight we've got to cover, I believe, right around 67 slides to keep on track with Pathophys. I'll be honest with you guys, we might take a little more breaks than normal. I've actually been homesick the last couple days. My voice just is kind of coming and going, so if you hear any squeaking, it's not on purpose, just because my voice box doesn't want to work. So last week we kind of talked about some boring stuff. I'll be honest with Pathophys. We talked about atoms and how atoms bond to each other in the periodic table of elements, and how we can combine these elements to make larger elements, go from simple to a more complex molecule. As far as cells and atoms and all that, I've done a lot of looking over it the last week. There's not a whole lot. Don't go too far in depth into that because you'll go down a rabbit hole when you start looking at, like I said, all molecular compounds and all that. Take that with a grain of salt. A lot of that stuff isn't necessarily knowledge that we necessarily have to have as a paramedic. And a lot of that really falls in like anatomy and physiology as well. So again, don't if you felt lost with some of that stuff, it's okay. A lot of it is fluff, as I like to call it, to put in here to almost expand the chapter. If it was something I felt was vital for you guys to learn, I would have hit on it a lot more. And then there's some stuff in here even tonight when we start talking about cells and different types of cells, such as eukaryotes and prokaryotes. That again, I probably wouldn't pay a whole lot of attention to that. But when we start talking about like diffusion, maybe like osmosis or simple diffusion, that I'd probably pay a little bit of attention to. When we start talking about fluid shifts and what type of fluids we should be giving our patients, that's kind of important stuff that we really need to know when we're dealing with and caring for patients and knowing how to treat them. Before we get moving, do you guys have any questions over anything so far? Or is there anything I can provide you guys, in your guys' opinion, that might be able to help you out with this chapter a little bit? All right, we'll get moving then. Like I said, it's not going to be a super long night. We have about 67 slides to cover. I believe it's slide 117 is where we stop. And then we've got 2 more nights, obviously, with Pathophys, and then a review before our big final. So when we talk about the cellular level, what is important for us as paramedics to know is, the components of a cell. So obviously a cell is its own entity, capable of functioning on its own. Just anything that we have has cells, whether it be a prokaryote or a eukaryote, and anything. I mean, any object, any person, any animal. When you start talking about cells, there's some major components here that really you need to know of. So your nucleus is obviously like the brain of your cell, right? It does all the thinking, it does all of the rationing, and decides what's going to happen next. If maybe we're going to merge with another cell, or if we're going to maybe attack something, or however it might be, that's where really the brain box is. And then you have your organelles, which really carry out the processes that the nucleus want performed. Now, when I said everything has cells to it, essentially, I mean, look around your house, everything has a compound that's made up of it, has cells. But what it really, the difference is whether it's a prokaryotic or a eukaryotic cell. Prokaryotic cells are essentially, I call them dead cells. They don't contain a nucleus, they don't contain organelles, they don't really do any thinking. They're just there. They're there because of, whatever the material might be. Wood is a really good example, because wood doesn't mutate. It stays in its form constantly. Those are essentially prokaryotic cells. As for when we talk about eukaryotic cells, which are living, they contain a nucleus, they contain organelles that contain other things such as like your Golgi complex, parts of the cell that can actually function, parts of the cell that are actively moving. So if you look under a microscope, a prokaryotic cell is going to look like nothing but a dead ring. It's not going to have anything on the inside of it. It'll almost look like a honeycomb with essentially nothing inside the combs. As to where a eukaryotic cell, you'll actually be able to see processes inside the cell moving on their own. You'll be able to see things being transported in and out. It's almost like a little city. Then we have our makeup of our cell here, obviously. This is what we look like. Obviously, our nucleus is our middle part, and then our nucleolus is our eye, if you would, of the nucleus. That real dark reddish spot almost in the middle is essentially the center of the brain. Now, cells are also surrounded by fluid. Now, what type of fluid really depends on what type of structure the cell is found within. The fluid has to shift from time to time. A good example of this, and something that's really good to remember, especially being a paramedic, is that salt obviously is something that we constantly deal with. Whether it be like sodium chloride, whether it be salt in a person's diet, it's something that we should be pretty familiar with, and it's abbreviated by Na. That's its element. Na is sodium. Now, what happens to somebody's body if they load up with salt? What happens with fluid-wise?
They retain the water with it.
They retain water. Fluid will always follow salt. So that's why those patients that are generally withholding fluid are taking some sort of diuretic, or they're taking something to help excrete a lot of the excess sodium, because as the sodium disappears, the fluid will disappear as well. Now, when somebody gets hopped up on so much sodium that it starts to, enter these cells, then we have a shift in what we call from extracellular space to intracellular. And what I mean by that is fluid outside the cell then comes into the cell by a process generally called diffusion. Now, there's a couple different types of diffusion here, and I highlighted the ones that I felt were very relevant to paramedicine. The first one being simple diffusion, which is the random movement from region of high to a region of low concentration. A good example of that, if I have let's say a balloon and I put it under my sink to fill it up, or two different balloons, the one that's going to fill up a lot faster is the one that has nothing in it. If I already have a balloon that's full of water and I'm trying to fill it up even more, it's going to fill a lot slower as compared to that balloon that has nothing in it, just because we're going from a high concentration to a low concentration. Facilitated diffusion is the movement from high to low concentration again, but it has a helper protein or a helper molecule that makes it go through a channel. So think of these channels as like a door to a hallway. Well, to get into this hallway, they have to have an escort. So before they can move from their concentration to high to low, they have to have somebody escort them into the cell, essentially. Then we have osmosis, which is the movement of water from high concentration to low concentration as well. And then active transport, which requires energy, requires ATP to be able to move that concentration from high to low as well. But if you look, something common is that they all move from high to low. Neat little diagram, I guess, on kind of how it works. So if you look at the picture on the left here, you've got two different, we'll just say, molecules, fluids, whatever you want to call it. And they're separated by a barrier in the middle. You've got the same type of fluid on one side, same type of fluid on the other side. Now, the problem is that they each have high concentrations of each other. So they're going to want to move and combine with each other so that we get a balance of homeostasis or equilibrium. So if you move one picture to the right, you see diffusion happening. So they're kind of combining right now. And then the picture on the far right, you will have equal parts of either on either side of it. Water plays a huge role in what we do and how we manage our patients, because a lot of our patients either retain water or maybe have lost too much water. The average person, I want to say, is 70% water weight on average. So we should know a little bit on the process and how this all works. So when we talk about free water, we're essentially looking at almost like distilled water, if you think of it that way, on a shelf. Now, there's a couple different types. There's isotonic, there's hypertonic, and then there's hypotonic. So isotonic, meaning the solutions on both sides of that membrane, remember that little wall in the middle, are equal. Okay. Hypertonic, one side of the membrane is more concentrated in the solution on the other side. And then we have hypotonic, which it doesn't have listed here, which is obviously going to be the opposite of hypertonic. So we're going to have a very low concentration. Now, just some examples for either one, because fluids that we give our patients, we need to know if they're hypertonic or hypotonic or isotonic, just for the simple fact that sodium chloride contains salt. So if we have a patient that is retaining a lot of fluid, giving them more salt is not going to help them at all. It's actually going to make their condition worse. So example of, let's just say, isotonic fluids. 0.9% normal saline. Our normal saline that we carry on the ambulance every day is an isotonic fluid used for hemorrhaging, severe vomiting, diarrhea, GI problems, hyponatremia, which is low concentration of sodium. Sure, we can give them sodium a little bit. And like I said, normal saline doesn't have a ton of it, but it still does have some, 0.9%. Lactated ringers is another isotonic solution. Lactated ringers is used more often in burn situations or in some traumas over normal saline, just based off the properties that it has, and the pH is a little bit different. Something interesting that was said to me, I went to a trauma conference one time, and we were talking about fluid replacement in the trauma patient. And it was, okay, hey, this person's already losing a lot of blood, so they're becoming acidic naturally because they're losing hemoglobin. And then we want to give them normal saline on top of being acidic, which is just going to make them more acidic. So it was one of the trauma surgeons actually here at Mercy, and his big thing was, in traumas, we should be giving blood, not normal saline. He goes, I get pre-hospital and an ambulance, you guys don't carry blood. But that's where we started looking at things such as permissive hypotension. Let's give them enough fluid just to keep their pressure up, 80, 90 systolic, but not too much where we could actually hurt the patient and wash away those clots as well. Example of a hypotonic solution. I don't think anybody carries this, but it'd be like 0.45% sodium chloride. So normal saline, but a little bit different concentration of the sodium itself. D5W, and I don't mean D50, D5. So when you have it hanging a D5 drip, that's also hypotonic solution. And then when we get up in percentage of like sodium, then you would start to see your hypertonic, such as like 3% sodium chloride. That's obviously going to be a hypertonic because it's a lot higher percentage. From this slide, there's something I really want you guys to remember. We're going to go through cardiology next semester, and cardiology is probably the point where I feel like it's really the make it or break it point for you guys as paramedic students. It is probably the hardest part of paramedic school, is learning cardiology and learning how the heart functions and learning what we should be looking at within the heart and the sodium potassium pump. Our heart has a natural impulse to it, has a natural electrical discharge called automaticity. Now, for that to occur, our heart has to have something that creates electricity, and how it does that, and it creates its own positive charge, is through the sodium potassium pump. We normally have, sorry, I'm trying to clear my throat. We normally have a cell that has sodium in it, and we normally have potassium outside the cell. That's just how it works with fluid. Well, how the sodium potassium pump works is when it's getting ready to discharge, when you're getting ready to see a spike on like on their forelead, when you're getting ready to see their heartbeat, is because they had a reaction to their sodium potassium pump. These channels opened up for their cardiac cells. Sodium rushed out of the cell, potassium rushed into the cell, and changed the electrical charge. The cardiac cells normally sit about negative 90. So when we do this, they will actually jump up to about plus 180, I believe. So they go from negatively charged to positively charged. That's how we're able to see an EKG. It's just based off of automaticity and based off the sodium potassium pump. And again, we'll talk about that a whole lot more next semester when we get into cardiology, but I want you to keep sodium potassium pump in the back of your mind and maybe even do some research on it. So our body and fluids, like I said, intracellular fluid, and what I mean by intracellular, again, is fluid within the cell. 70% of our body weight is intracellular fluid. Extracellular fluid is roughly 30, could be up to 30%. Interstitial fluid, which is fluid, it's not intracellular, it's not extracellular. A good example of that would be like fluid in somebody's lungs. It's not occupying anything besides a void space, can make up to 25%. And then intravascular fluid, such as us putting normal saline into somebody's vein, can make up to 5%. And if you look at the numbers on the right, that is a massive amount of fluid that we can shift in essentially a day. I've seen patients before literally that have lost 15 to 20 pounds in a day alone, just based off of fluid shifts. So it makes a huge difference when we start talking about what fluids we're going to give our patients and how we're going to replenish them. Again, ECF, or extracellular fluid found outside the cells of the body. Intravascular, found outside the cells, but within our circulatory system. So within our veins, within our arteries, but they're not in our blood cells, right? And then interstitial fluid, which is fluid found outside the cell membranes, but not in the circulatory system. So a good example, again, is a patient with CHF, retained fluid in their lungs. It's not in the intravascular space. It's not in the intracellular space. It's just kind of floating there in its own little void. Now, on both ends of the age spectrum, such as our very young patients and our very old patients, they're both at risk for dehydration and both at risk for fluid disturbances. Why is that? So, young people, let's take an infant, 1 month old. Why is it that you think they couldn't shift their electrolytes or maintain fluid at such a young age?
Undeveloped kidney function?
Possibly, yeah, undeveloped kidney function. It's really just an undeveloped system. They're not really sure on how to do that yet. You got to think they don't even really have an immune system built up yet at that point either. So their bodies are really trying to grow and figure out how they want to function and what's the right way of functioning. And, they have all these things going on at once. And then in our elderly populations, we lose that ability as well. If you've ever heard the term or heard that, the older you get, the younger you get as well, is you essentially digress. In our elderly populations, their body systems aren't able to work like they used to. Maybe they're not able to filter like they once would, and so that makes them retain electrolytes. My grandfather is a perfect example of this. He has kidney issues right now. He's on a water pill because his kidneys aren't able to function like they normally would. So to help him get rid of his excess fluid, they had to put him on a diuretic to help flush that stuff out because, again, he's getting older. He's 87 years old. His kidneys don't function like they used to. So in a lot of the disease processes that we'll go through, you'll see that on both ends of the spectrum are our patients most at risk. All right, so dehydration. What are some reasons that we get dehydrated? Obviously, gastrointestinal issues, everything you're seeing on the screen right here, increased sweating. But what are some actual reasons? Like, what are some things that we could get called to as to why a person's dehydrated?
Medication-related water loss?
Okay, medication-related water loss. Maybe somebody took too much of their Lasix, possibly. Okay, what else?
Hyperthermia?
Okay, so temperature changes, sure. Flu-like symptoms obviously can cause GI upset, whether it be diarrhea or vomiting. That's why, you're starting to, in Vegas, they have them, you're starting to see them come up around Iowa. They have like those IV clinics for people that essentially have a really bad hangover. When that happens, you have a fluid shift. And it's not that you don't have fluid retained, it's just your fluid isn't sure where it should be going. So when we give an intravascular fluid, it's essentially that fluid that's already inside your body looks to see where that's going and then tries to follow it. That's why later in the day, people that have been drinking heavily the night before, they'll generally have to use the bathroom, and then that's when their kidneys really start kicking in, is because their body essentially got a restart and said, hey, maybe I need to get rid of this excess alcohol, this excess acidity. What about fluid retention? And does fluid in the lungs necessarily mean that somebody has intravascular fluid or has fluid that is, in their circulatory system? There's a fine line with patients that have edema in their lungs, because we don't want to give them too much fluid. If we have to give them fluid, we don't want to give them too much and overload them, because then the excess will spill over into their lungs. That's why patients that have CHF and that we're worried about, edema, we actually listen to lung sounds pretty frequently while we're transporting them. It's just because we don't want to overload them. But again, we might have to give those patients a little fluid to kind of get some things going, maybe get their kidneys kicked in, right? So that they can start to filter out some of that stuff. Plasma losses, so blood loss due to trauma, possibly. Okay. Temperature changes, like we'd said earlier, except think hyperthermia. Think somebody that's, stranded in a desert or something like that. So how we replace this fluid really depends on how the fluid was lost. Somebody that was out jogging, somebody that was, out exercising or something like that. We've been on the calls. They're cramping up now. They have heat cramps, and we want to give them normal saline. That's fine because they were sweating, right? And as they were sweating, they were losing fluid, but they were probably also losing electrolytes such as sodium. So replacing that with sodium chloride or normal saline would probably be just fine. But then you have the patients, like in the case of burns, that they're not essentially losing fluid, but what has happened is that fluid has shifted, okay, almost to an extracellular spot. That's why patients that have burns and everything can be potentially dehydrated, but yet their body isn't losing any fluid. They're not urinating or anything like that. It's because that their body has shifted that fluid to try to treat the burns themselves. So that's where we look at giving something such as lactated ringers. And our patients, again, that have edema, whether it be pedal edema or it be, wet lung sounds, be careful if you're giving them fluid. Because, and I'm not saying you shouldn't give them fluid, just be careful. And make sure you're watching and listening to what's going on. And one thing we suck at as paramedics is listening for lung sounds, I'll be honest, because we're going down a bumpy road where, we think we hear something, but we're not 100% sure that we're hearing it. So just be careful with that. And I would be, again, listening to lung sounds frequently if you're giving fluid to somebody that potentially already has CHF and this fluid could already be backing up in their lungs. We talked a little bit last week about different ions or particles that we have. Cation ions, remember, they have positive charges, as to where anions are negatively charged. Anything with an in front of it usually means without. So an without ions, so again, negatively charged. Some example of our positively charged electrolytes: sodium, potassium, calcium, magnesium. And what you'll learn next semester is that a lot of these play a role in our cardiac function. That's why we get patients that are severely dehydrated. We can start to see them throw some weird cardiac rhythms. It's not because their heart is dying. It's because their heart doesn't have the electricity that it needs to be able to function correctly. And then some examples of our anions. So our negatively charged ions: chloride, bicarb, phosphate. So when our fluid, let's hop back to diffusion for a second. When our fluid shifts, right, it does this, how it enters cells, how it enters different membranes, is it does this almost through channels. In these channels, think of a sponge. If you were to run fluid through, or run water through a sponge, the water doesn't just run out like it's running in, right? It accumulates in the sponge and then it slowly trickles in. That's essentially how fluid moves into a cell or moves into a membrane, is you have these little holes all over these channels that the fluid has to go through And remember, it could freely go through it, such as simple diffusion. It might have to be escorted with ATP, with energy, or it has to have a doorway that has to be open for it as well. So there's different types of diffusion when we talk about that. Electrolytes are almost like I'm trying to think. That game, when it wasn't even a game, it was when I was a kid. We had this thing that you try to put the circle as a kid in the little circular spot. You try to put the square in the square, the triangle in the triangle, the star in the star. Electrolytes are similar to that. They're not so easy to pass through because they have to be almost escorted in. As to where fluid, if we're talking just an isotonic fluid, 0.9% sodium chloride, can pass freely through a cell. When you start getting into hypertonic solutions, because they have an electrical charge, they're not so easy to enter the cell because something has to come out to allow that electrical charge in, just like the sodium-potassium pump. We get sodium that has to come out of the pump before potassium can come in. All right, edema. What are some reasons that we can get edema? And don't say CHF. What are some other reasons that you can think of? You're all competent EMTs. What are some reasons you see edema in somebody?
Like blunt force trauma?
Okay, trauma. Absolutely, trauma can cause edema, right? Maybe it's due to a compression injury. Maybe it's due to a crush, and we have edema pooling up in one area. Sure. What else?
Somebody who did dialysis?
Dialysis patients? Sure, the missed dialysis. How many people here have ever transported a patient that missed dialysis? What do you most likely see with them? Okay, let me back up for a second. With edema, if I have edema in my lungs, which side of my heart is probably not functioning correctly?
Left.
Okay, why? Explain that to me. So blood comes into the heart through the right side. It then travels over to the lungs, does its thing, and comes back to the left side of the heart. So why would that make sense, though? You know what I mean? But how does that work then? It's really almost based off vacuum. The cardiac system is a closed system, right? So as fluid goes into the lungs, such as blood, and we get the exchange of carbon dioxide and oxygen. If the left side of the heart isn't functioning correctly, you're absolutely right when you say left. If the left side of the heart isn't functioning correctly, it doesn't have the force to pull that fluid from the lungs, right? So when we start to, hear lung sounds and everything, you should right off the bat be like, okay, we're looking at some, potentially left-sided heart failure, as opposed to if it was, edema in our extremities, we'd be looking at right-sided heart failure because the right side of the heart isn't able to effectively pull that fluid from the body. It took the longest time for me to realize that. For some reason, I was like, that makes no sense. Like, that makes zero sense. But it does make sense once you think about it. So we have something inside of us called ADH, or vasopressin. And what's funny is vasopressin actually used to be what we would give patients in cardiac arrest. And we didn't give we gave vasopressin instead of epi. We didn't give vasopressin for the same reasons we give epi now. We gave vasopressin during cardiac arrest so that they would retain fluid and their body wouldn't try to get rid of it. But that is essentially, vasopressin and ADH are the hormones that are responsible for water retention. So if we have a massive amount of ADH buildup in our patients, we're going to potentially have a lot of water retention. As to where if we have a low amount of it, we could potentially have fluid loss or fluid loss in distribution. All right. So what are some reasons we give IV fluid? What are some reasons we start an IV and give fluid?
Low blood pressure.
In order to deliver medication.
I got two of you at once. What did you guys say?
Low BP.
Okay. So hypotension. Okay. What else?
To facilitate medication delivery.
Facilitate medication delivery. Okay. What else? I'm gonna give you guys a little tip into respiratory. Why would we give fluid to somebody that's potentially in respiratory distress? So in the bottom of our lungs, we have this fluid called the SOL layer, SOL, and it's a gel-like layer that essentially has these little hairs on it called cilia, and these little hairs' job is to essentially collect particles that shouldn't be in the lung, and they essentially evacuate them out. They just constantly move back and forth, but they have to have that SOL soluble layer. Now, if somebody is really dehydrated and that SOL layer is diminished, then their cilia aren't able to do their job, and that's where you'll get really dry. You know, patients feel like their lungs are burning. They feel like they aren't able to cough anything up. So we can essentially assist that by giving some fluid and help by rebuilding that soluble layer within inside their lungs. There's multiple reasons we can give IV fluid besides hypotension. You know, this is being paramedic school and learning and going through your field rotations, your clinical rotations, and learning about disease processes is thinking a lot more outside the box as to why we would give fluid. And it's not just for hypotension, right? Like you said, maybe to assist with medication delivery. Sure. Now, let me ask you this. When we're talking about fluid delivery, let's talk IV catheters for a second here. And I'm not saying size of catheters, but if we want to do massive fluid replacement, what size and length of catheter would we want more than anything? Like, do we want shorter and fatter? Do we want longer and thinner? What are we thinking here? To maximize fluid delivery, what would you say?
The bigger, the
Short and
better.
fat.
Short and fat, right? Because we have diameter, so we're going to have a lot more fluid that comes through that pipe. And then shorter, because the less distance this fluid has to go, the better it is for the patient, the more we're able to get in a shorter period of time. So, yeah, absolutely. Now, there's a common misconception here. I was able to go through a tactical medic class in Maryland, and one of the things they taught us, we didn't start anything smaller than an 18 gauge in this week-long course. And one of the things they taught us was the difference between a 16 gauge and the difference between an 18 gauge in terms of fluid delivery was very minute. But what mattered was the distance and the length of the catheter. So again, something to think about, whether you're grabbing for a longer catheter or you're grabbing for a shorter one. All right, some components of blood, right? So blood transports nutrients. It transports deoxygenated blood, so carbon dioxide within the blood. It transports oxygen within the blood, and it helps us retain heat. How does it do that? When we become hypothermic, how do you think our body helps by regulating heat? Like, how does our vascular system help with heat when we start to become cold?
Constricting the outer capillaries in order to retain the heat close to the core.
Okay. It actually, it really depends on what stage we're in, because depending on when we're initially starting to become cold, it'll actually vasodilate first. Our veins open and get wide to allow for a lot more fluid to come in to try to warm us up. But when we start to get in cases of like severe hypothermia, think of somebody that's maybe fallen into a lake or a river or something like that. Yeah, you're absolutely right. Those vessels start to constrict. And the reason they do that is they're trying to conserve blood, and they're trying to bring that heat towards our core, which is our abdomen and our chest. We shunt blood away from our extremities in that point. And because the body says, you know what, I can live without an arm, I can live without a leg. I gotta keep this person alive. I gotta keep their brain functioning, I gotta keep their heart functioning and their organs. So they will essentially shut down blood supply to the extremities. But when we're starting to essentially, maybe you're in your house and the thermostat's turned down a couple degrees colder than you want. your vascular system will actually vasodilate, so that pipe gets bigger, allowing for more blood to essentially heat you up. It's weird how our body works, and we don't even realize it. Plasma is our liquid portion of our blood, right? That's the actual fluid component of it. Now, when we start talking about blood cells, we got different types of blood cells. We have red blood cells, which are erythrocytes, you could hear them referred to as, and then white blood cells, which we call leukocytes. Kind of makes sense because leukemia is a cancer of where our body is essentially attacking itself, right? We have this massive buildup of white blood cells, and these white blood cells are essentially attacking ourselves. Kind of makes sense. And then we have thrombocytes, which are our platelets themselves. Now, when we start getting into like next semester and third semester, we'll talk about different diseases of the platelets, potentially like sickle cell. You know, those are misshapen platelets that can actually cause severe pain in some patients. So erythrocytes contain hemoglobin, and hemoglobin transports oxygen, but hemoglobin also transports everything else, right? Again, a pulse oximeter, and I told some of you this Thursday night, a pulse oximeter does nothing but measures the amount of saturated hemoglobin. It doesn't measure oxygen. It looks at your hemoglobin and says, okay, how much of my hemoglobin is taken up by something? That's why if we have a patient that we put on a pulse ox and it says, oh, 100%, okay, but 100% of what? You know what I mean? And it's interesting, in shock cases, in patients that are maybe have severe blood loss, they can have a low pulse ox because they have a loss of hemoglobin. Our leukocytes or white blood cells are obviously going to be responsible for fighting infection. Okay. Thrombocytes, major role in blood clotting, sure. Now, something interesting. I just learned this 2 years ago, and for some reason it blew my mind. Does anybody know what pus is? You're all going to guess it now. Like if somebody has a wound and they have pus, or even like a pimple or something like that, what that white substance is. It's a congregation of white blood cells that came to an area to fight infection. When I learned that, I don't know why, my mind was blown. So, blood components. 54% of our blood is made up of plasma. 45% of it is made up of red blood cells. And white cells and platelets make up about 1%. And that can change based off the patient, maybe based off a disease process, such as leukemia. We will then see their white blood cell count rise, indicating, and at first they think they have an infection of some sort until they have a prolonged white blood cell count, indicating that they have an issue, and it's most likely leukemia in that sense, and it's essentially fighting their own body. When we start talking about, you'll hear this term a lot through paramedic schools, hematocrit. Hematocrit is actually the percentage of blood occupied by red blood cells. So when I think of hematocrit, I think of if I was to take plasma away, if I was to take all the fluid, everything else, the thrombocytes, and all that away, I would essentially have this little red powder. And that little red powder is hematocrit. All right, let's take a 15-minute break, and then we'll come back here and keep going on resuscitation fluids. All right. So I kind of talked about this a little bit already, which was what fluid should we be using to resuscitate our patients, depending on what's going on with them. Obviously, when we're talking about some sort of blood loss, such as hemorrhagic shock, as you see there, our first choice would be whole blood. You're going to see that mainly in aeromedical, such as your either fixed wing or rotorcraft helicopters. Second choice would be packed red blood cells. Third, plasma or a substitute of plasma. Again, they're looking for the thing that might have the same nutrients as blood. Their last and final choice is obviously lactated ringers and normal saline, which is what is generally our first choice because that's generally all we carry. Shock due to plasma loss, such as burns. Again, what we're going to be looking at is lactated ringers because it has some of the properties, being the hypotonic solution that it is. It has some properties to replace some nutrients and some electrolytes, but it will never replace plasma. And then for dehydration, sure, saline works great for that because as people become dehydrated again, they're losing electrolytes such as salt. So sodium chloride works perfect. Now, let's talk about blood for a second here. What is the universal donor when we talk about blood types? Does anybody know?
O negative.
Okay, O negative. What's the universal recipient?
Anybody. Oh no, AB.
Do what?
Nothing. I messed that up. Is it AB?
No, you're
is
close.
Universal recipient.
Yep, AB positive. So O negative is your universal donor. AB positive is your universal recipient. Means they can receive any blood type. But in most of our patients, that before they can actually receive blood, and this is going to be obviously prior to, like, a helicopter isn't going to do this, but if they're in a hospital setting, they're going to do what's called typed and cross-matched. So they're going to look and make sure and verify that the blood that they're going to receive will work with them, so they don't have any sort of allergic reaction to the blood they're going to be receiving for the transfusion. So they will then generally take a blood sample, and again, this is when we have a little bit of time. They'll make sure that they're compatible with what blood types. An issue with transfusions obviously can be allergic reactions. It can be how the blood is being transfused itself. Is it being done too slow, so we now get clotting in our line? Is it not being put in through the right drip set? As many times as I've honestly transported somebody on blood, I don't think I've ever had an issue with some sort of reaction. The hospitals are generally pretty good about giving them the type of blood they need. But yeah, O negative is our universal donor. That's what we usually give to everybody until they're typed and cross-matched. So you see a helicopter carrying blood, it's O negative is what they're doing. We carry pre-hospital in the ambulance things such as colloids and crystalloids. Colloids being things that remain in intravascular space for extended period of time, such as like lactated ringers, and then crystalloids, which are going to be more towards our sodium chloride. Yeah, lactated ringers also falls in that category, but when we talk about crystalloids, we're mainly leaning towards sodium chloride. Most commonly, what we see in pre-hospital care, and I'll be honest, is the two top ones: lactated ringers, again, burn patients, and then 0.9% sodium chloride or normal saline. Some services carry 5% dextrose in water. Again, and a lot of times when they give that, they're also trying to replenish sugar at the same time. Does anybody's service on here carry D5W that you know of? I didn't think so, and you're really going to see that more in like a critical care setting as well. We're looking at giving D5 because a lot of times when we're giving D5, it's because we're mixing up a medication, because D5 is really receptive to almost all medications. So when we do that, that's generally the reason for it and why it's being carried. Skip over our cells here. Except this. Cellular respiration. we have aerobic and anaerobic, right? How the cells are functioning, how the cells are able to receive their nutrients. Aerobic requires oxygen. Anaerobic does not require oxygen, right? The problem is anaerobic runs off ATP, runs off that energy. So if we start to run out of ATP, the anaerobic process will no longer work. So normally how we're functioning right now is aerobic metabolism. Now, in the case of maybe ischemia, which is obviously lack of oxygen through blood supply or lack of blood oxygen, we would be seeing like anaerobic metabolism because they're not getting the oxygen they need, but they can only do that for so long before they start to shut down. So please remember aerobic and anaerobic and the differences between the two. All right, hypertrophy. When something increases in size, or such as a tissue or an organ. Does anybody know anybody that has some form of hypertrophy by chance? Good example of hypertrophy. Arm wrestling is a sport, believe it or not. And the dominant arm that they use when they're arm wrestling is obviously a lot larger than their other arm. And that's because they work out that arm constantly, because that's the sport that they compete in. So what you'll notice is if you look at one side of these patients or one side of these people compared to the next, they have what's called hypertrophy, which is enlarged muscles or enlarged tissues on one side of the body as compared to something else. And again, that's due to increased physical demand to that essential muscle, to that tissue, to that organ, whatever it might be. That's what we call hypertrophy. Now, on the other end of that, we have what's called atrophy, which is a cell decreasing in size. And a lot of times we also see this in our elderly patients. As they get older, they lose muscle tone, right? Maybe they might drop some weight, whatever it might be. My grandfather was a perfect example of this, 87 years old. He used to weigh over 300 pounds. He weighs like 105 pounds now. Just his body, it started shedding itself essentially, and he atrophied in size. I mean, he doesn't really have any muscle tone at all. And part of that is because he's actually now on a restricted diet, to help him with his diabetes and all that. So when we talk about atrophy, we're talking about a decrease in size something, as opposed to hypertrophy, which is an increase. And then we have metaplasia, where an adult cell type can actually change from one to the other through mutation. And they really change because they're being stressed, they're being forced to change for some reason. Good example would be such as like hypertrophy. So changing from what they are into a much larger cell for some reason. And then when our cells get so stressed that they are unable to function, or maybe they have a lack of oxygen, they go through cell injury and cell death. And we'll talk about this a lot in cardiology as well. We start talking about patients having STEMIs. When cells are stressed to the point that they can no longer adapt or are exposed to toxic agents, cell injury can result. And when we talk about that within a heart, we can actually see that in a 12 lead. And that's due to lack of oxygen for so long in that aspect of it. But sure, due to medications, think of cellular death or cellular injury if somebody's without oxygen for a while. Think of somebody in cardiac arrest. And I think I've told you guys a story on a code that I was on one time, where the guy ended up being brain dead afterwards because he just was without oxygen for so long prior to us initiating resuscitative efforts. So that's a perfect example. The cell was going based up with anaerobic metabolism, right? Without oxygen, it was how it was functioning until it couldn't do that anymore. And so then we went from cell injury, when it starts to become injured, to cellular death. When that happens, when we get a diminished blood supply or a diminished oxygen supply, we get what's called ischemia. Ischemia is what happens when somebody is having a heart attack. Those blood vessels, their coronary arteries, are clogged, generally with plaque, generally through a disease process called atherosclerosis. And as that plaque thickens on the walls of their coronary arteries, it cuts off the blood supply. Well, blood carries oxygen, right? So they're essentially receiving decreased blood and decreased oxygen at the same time. And that's really where ST elevation comes from. If you guys have ever heard the term ST elevation before, where we start to see like tombstones on somebody's 12 lead. That's what we're looking at is cellular injury and cellular death due to ischemia. Obviously, we're familiar with hypoxia, which is the decreased amount of oxygen that we have available to a patient. But we can also have what's called hypoxemia, which is decreased oxygen levels within the blood. This is pretty important, especially at the EMT level. So cardiac patients, at least when I was an EMT, this is how it was. Cardiac patients, as an EMT, what are you taught to do? How are you taught to treat them? Seriously, what's your protocol for it? Do you put them on oxygen?
Yes.
I'll never forget. I was an EMT. I think I was working at Mercy Ambulance at the time, and I had a patient that we brought into the ER and had him on oxygen. We were a basic truck that night, and was having chest pain. And I remember the doctor kind of scolded me for having him on oxygen. I was like, well, I don't know what I did wrong. Like, that's what we're taught to do. It wasn't until I went through paramedic school that I realized we can over-oxygenate our patients. And when we do that, we're actually creating what's called free radicals. And those free radicals are not good for the body because they essentially start attacking the body at that point. So by over-oxygenating those patients, that's why when we go through like ACLS and PALS and everything, as paramedics, we're taught to keep people's oxygen level between 94 and 99% because we can't measure anything over 100. So we don't want to over-oxygenate, especially our cardiac patients, because we will get that free radical where we now have them attacking the body systems. Okay. All right, tissues. So tissues is obviously when we get a makeup of cells that serve a common purpose. Maybe they all work for the same thing. Maybe it's they are the same type of cell. They all have the same function. This could be skin. This could be muscle. This could be the nervous system. Connective tissue such as ligaments or tendons. Sure. So we also have within this germ layers. Anything that begins with endo usually means innermost. So, and you know, in this case, we're talking about the innermost germ layer, the derms, right? Mesoderm, meso means middle germ layer. Ecto, outermost germ layer. And then we have what's called the epithelium and the epithelial tissues. Epithelial tissues cover body surfaces. That's what we're used. That's what skin is essentially, is a large tissue that just covers our body. Now, what is the primary role and responsibility of skin or our tissue on the outside of our body? What is its role?
Separate us from the environment.
Okay, protect us from the environment. What else? It's really the first line of defense against the environment, right? What else?
Temperature?
Regulate heat transfer.
Yeah, temperature and regulate heat, right? Without that, we wouldn't be able to. And we do that through the blood vessels that are in our skin. Remember, they constrict or they vasodilate to help with temperature. We have our connective tissues, we have our muscle tissues, and then we have our nerve tissues. So connective tissues, obviously skin is a really good example. Muscle tissues would be muscles. And then nerve tissue would be any part of our CNS system, our central nervous system. So our spinal cord, our brain, that are really helping coordinate, that are sending and receiving a signal through neurons, through axons, which we'll learn about here shortly. Our epithelium, or our skin, forms a barrier between an organism, us, and the environment, right? And on our epithelium, we have those germ layers. They're essentially a barrier of themselves as well. Now, again, this protects us against the environment. Where you also, you got to think of this. We kind of adapt, right? Majority of my family is from Southern Italy. Okay, Southern Italian people are very dark complected. the reason for that is because in southern Italy, the sun is out like 99% of the time, right? It's not necessarily that they're dark complected from being sunburnt. It's their body has adapted and it prevents them from essentially being sunburnt, right? The darker complected you are, the less ability you have to become sunburnt. It's just how our body functions. It's how our tissue can also work in a way to protect us as well. Different types of tissues, obviously. Our lungs are made up of a tissue that also contain that fluid that I was talking about earlier, that soluble layer, that soul layer. Our skin is mostly adipose tissue, believe it or not. It's mostly fat tissue. Tissue within our esophagus, tissue within our trachea, all different types of tissues, all forming and doing different functions. So, squamous layer, lining of the heart, blood vessels, air sacs of the lungs, okay, allows passage of material by diffusion. Being as to where it's at, the heart and lungs, it has to be able to exchange nutrients and fluid relatively quickly. We have what's called our cuboidal cells. These are used in our kidneys, glands, where we're excreting nutrients, okay? And then our columnar, digestive tract, esophagus, uterus, anywhere, GI, anywhere where we're going to be absorbing enzymes or getting rid of or secreting mucus would be considered a columnar epithelial tissue. I'm skipping over some of the stuff because I don't want you to look into it again. Now, different types of connective tissue, right? So we have what's called loose tissue between our muscles, our blood vessels, really just right underneath the surface of our skin. Its job is to protect our organs. In case of a fall, in case of any blunt force trauma, in case of any injury, its job is to surround and protect our organs, right? That's essentially why we have fatty tissue for the same reason. But fatty tissue also stores energy. Think, as we eat something, it's metabolized. Any excess that isn't used for nutrients is then converted into a fatty tissue. And then we have dense tissues, such as ligaments and tendons. Ligaments attach bone to bone. Tendons are bone to muscle. Cartilage. Okay, we can tear cartilage, right? Maybe sports injuries. Even honestly, just by performing daily functions, we can tear cartilage. Bone, whether it be the solidity of the bone, the actual structure of the bone, or the bone fluid itself, such as bone marrow. Those are all different types of connective tissue. Now, types of muscle tissue. This is pretty important, so I would pay attention to this one. Skeletal muscle tissue, right? Connects our muscles to bones. So anytime, think of a skeleton, think of all the muscles that surround each and every bone in our body. So think of your arms. You have your triceps, you have your forearm muscles, you have your biceps, you have your you have the fat on the palm of your hand that essentially serves its own purpose as well. Everything has a purpose, and there's a reason it's connected there. So those are your skeletal tissues. Cardiac muscles. Our heart is nothing but a giant muscle with 4 different quadrants that has a role in itself, whether we're bringing blood to the heart or we're taking blood away from the heart. And then we have smooth muscles, such as blood vessels, such as our urinary system, such as our digestive tract. Okay? So connective tissues, again, with skeletal, are connecting muscle to the skeleton. Cardiac is going to be our heart. As where smooth is going to be, such as our, even our esophagus itself has smooth muscles. Blood vessels, urinary system, and digestive system. nervous tissue. We know the CNS system. We know the central nervous system. It's our brain. It's our spinal cord. It is what sends and receives signals. It is the main brain box for our body. Okay. It sends electrical impulses. That's why we can tell and detect brain activity through something called an EEG. We can tell if we have an electrical impulse or not in the brain to determine brain death in some patients. Now, how they do that is through neurons, which transmit. They take that electrical impulse and they send it down this long pathway. I've got a diagram of it right here. Here's your neuron. So we have a nucleus, just like a cell, where this is going to, essentially the signal is going to start. The signal starts and moves down. Let me get my little pen out, your laser pointer. So from a nucleus, the signal is going to transmit down through our axons, which are essentially a tunnel. Think of it as a tunnel system. This signal is going to go through and terminate at our axon terminal. Now, covering these axons is a sheath to protect them from being damaged. This is why in some patients, this is how they become paralyzed, is because when they damage too much of this, they're not able to send and receive those signals due to an injury. Abnormal tissue growth, cells grow and multiply in an uncontrolled fashion, would be an example of essentially a tumor, which is a massive uncontrolled cell growth. Some tumors are benign, meaning non-cancerous, and some do contain cancerous cells. That's where we go in and they have to do essentially labs on to make sure that they are not cancerous in origin. I'm drawing a blank for some reason. What is the process called where they check and see if a cell is cancerous or not? Biopsy. They'll perform a biopsy to see if the cellular growth is benign or not. All right. So going along with our tissues, when we talk about epithelial tissues, anything that generally begins with adeno has to do with a gland. And the easy way that I remember that is adrenaline is excreted through a gland. So adeno, again, has to do with a gland. A squamous cell, we know, is essentially a fatty tissue. Anything with melano, I think skin, I think melatonin. Anything with teratome is essentially a cell that has a lot more aspects to it. It's not just a cell. It could be a cell that's combined with another cell potentially. It's not simple anymore. It's more of a complex cell. The ones I would pay attention to are adeno, basal cells, which basal cells actually work by killing bad cells within our body, and then melano. I wouldn't pay attention to squamous or teratome. I'll let you guys look through this one on your own. It should be in your book. Table 1213. We're not going to go through all these, but there are a couple I want to point out. Fibro, having to deal with connective tissues. That's why some patients, when we talk about like fibromyalgia and they have constant pain, it's pain of those connective tissues. Lipo, that should ring a bell. That it's obviously a type of fat cell. Myo, meaning muscle. Osteo for bone. And then rhabdomyo, such as rhabdomyolysis for striated muscles. Look through. I will tell you guys this chapter. A lot of it has to go through this slide. This thing's like 260 slides. A lot of this is going to have to be you guys reviewing the cells and atoms like that. Like I said, I'm not going to put any of that on my final because I don't feel like that's fair to you, because I feel like a lot of it is impertinent or irrelevant information pertaining to paramedic school. But look through your book. Use your book as your resource, please. All right. Who can tell me, and I don't expect you to know what it is, what neoplasia is? It's another word essentially for tumor. It's an abnormal growth of cells or tissues within the body. So environment can be a risk factor, sure. When we talk about like different types of skin cancer, hormones can play a role in certain types of cancers. Absolutely, they can. If we have too much of a hormone, it can lead to a type of cancer. Carcinogens. Anybody that's in the fire service should know exactly what that is. Byproducts, possibly of chemicals that it can essentially that are cancerous. One of the things when I first got in the fire service, we dealt a lot with foam, and now foam is being, this big ticket item that can cause cancer, and everything we do cause cancer. It seems like in any field. So when we talk about the promoter, we're talking about that carcinogen that really sparked the cancer development. Where did this really come from? Remember, when we talk about diseases with an unknown origin, we're talking about idiopathic, but that's not what this is. This is, how did this really start? How did this really fester? And then what's the progression of it? What is the prognosis of this? What are we thinking what's going to happen? Is there a way it can be removed? Is there a way that surgically this can be removed? Can it be removed through chemo? Can it be removed through radiation? Once cancer forms, it becomes invasive. My grandfather on my mother's side, I believe he started out with liver cancer. He didn't want anything to do with it. He didn't trust his doctor. He thought it was all a lie. By the time that he thought he should probably go back to the doctor, it had spread to almost every organ inside of his body. And at that point, they deemed him terminal. And I think I want to say it was like 3 weeks from then until he passed away. So cancer is very invasive. It tries to invade as much as it can. It's essentially declaring war on your body, and it's trying to take as much land as it can. All right, that's slide 118. This next section, I think, is like, God, I want to say it's almost 100 slides in itself. Let's call it there for the night. I'm not going to push you guys any more than I need to. What I want you guys to review for tonight, though, before your next class, I want you to review your different types of tissues, okay? I want you to review the different types of cancers. I don't really care about the cell, and I don't know any paramedic that's even has ever been in a part of any testing that they've ever been a part of, or any part of their knowledge bank, to be honest. And I want you to look at the skeletal system. I know that wasn't outlined here, but I want you to look at the different parts of the body and the different muscles and the different skeletal bones that we have. And that way, when we come back next week to talk about diseases at the organ level as well, we're going to do a kind of a little review at the end of that class of different bones as well within the body, because that is something we should know. I always thought A&P should be a part of paramedic school, but it isn't. So that's something we'll talk about as well. So cancers, different types of tissues, fluids as well. I want you to look at what fluids your service carries, whether you carry, if you carry lactated ringers, I'd be shocked. But look, see what you guys carry. Do a review on that, and as well as your skeletal system. I would keep pushing on, but if I keep going, my throat's going to end up shutting down at some point. Do you guys have any questions for me before we kind of call it a night? Again, sorry I'm cutting it early, but we have 4 weeks later for this, and I really don't want to push you guys in one night. All right, we'll call it there. I'll see you guys back next week. I'll see some of you in skills Thursday night, barring me being there. If you have any questions,